السلام عليكم. معكم دكتورة إسراء لكلوك. أنا Assistant Professor of Pathology at University of Wisconsin-Madison. رح نغطي معاكم المale genital tract pathology in 3 lectures including penis pathology, testicular pathology and prostate pathology, and we will start with the first lecture covering penis pathology. penis pathology lecture. في هذه المحاضرة رح نغطوا congenital anomalies including hypospadias and epispadias, phimosis, inflammation including specific infectious disease and lichen sclerosis atrophicus, tumors of penis including benign tumors and malignant tumors. في محاضرة اليوم رح نغطوا المواضيع المهمة باش نفهموا الجينيتال male genital tract or penis pathology، ونركزوا على المواضيع المهمة اللي ممكن نشوفوا منها أسئلة في الامتحان. أول جزء من المحاضرة اليوم اللي رح نغطوه اللي هم congenital anomalies، and أول condition from the congenital anomalies is the hypospadias. Hypospadias is a Latin word composed of 2 parts, hypo and spadias. And hypo in Latin mean low, spadias mean opening. يعني من تعريف هذه condition, it's an abnormal opening of the urethra on the inferior surface of penis. زي ما نشوف في الصورة هذه عندنا urethra, it's curved and short and open in the ventral surface of penis. Normally, the urethra should be long enough to reach the tip of the glans, but due to the abnormal urethral structure, it's open in the ventral surface of penis. شنو the cause of this abnormality? It's caused due to failure of urethral fold to close. يعني لو نراجعوا embryology of the genital tract of male genital tract, we have the genital tubercle here, we have right urethral fold, and we have left urethral fold. Those urethral folds, they should fuse to form the urethral opening at the tip of the glands. Failure of this fusion will lead to hypospadias. The second condition is epispadias. Also, it's a word composed of 2 parts, epi, which mean above, and spadias mean opening. So, epispadias mean it's an abnormal opening of the urethra on the superior surface of penis. زي ما نشوف في الصورة هذه عندنا urethra is curved, short, and open on the dorsal surface of penis. Dorsal surface is equal to superior surface. This condition caused by abnormal positioning of genital tubercle, and epispadias also it's commonly associated with other GU congenital anomalies including bladder exstrophy. So other facts or معلومات تانية على congenital anomalies of hypospadias and epispadias. Hypospadias is more common compared to epispadias. Both cases is treated surgically, and we should use the foreskin to reconstruct the urethra. الحالة الثالثة اللي من الcongenital anomalies اللي رح نتكلموا عليها اليوم اللي هي الفيموسيس. الفيموسيس is less common compared to hypospadias and epispadias. تعريف الفيموسيس inability to retract foreskin to its normal position. يعني بالعربي إن الforeskin stuck in retraction position and the patient will not be able to retract it to the normal position because of small and narrow opening of the foreskin. So the constant retraction for foreskin backward on the penile shaft will lead to compression, congestion, and edema, and also associated with discomfort, feeling, and pain. Like constant phimosis can lead to secondary infection and long-standing phimosis can increase risk of penile cancer. Treatment for the phimosis remove the foreskin. In other words, it's just a circumcision. الجزء الثاني من المحاضرة will cover the inflammation or inflammatory conditions. Broadly, inflammatory condition of penis will divided in infectious disease or infectious condition, non-infectious inflammatory conditions. رح نبدو بالinfectious condition. Infectious condition equal to sexual transmitted disease of penis, and we will talk about the most common infectious diseases. This list in this list we will cover the most the disease and the causative organisms, including syphilis, gonorrhea, chancroid, granuloma inguinale, lymphogranuloma venereum, and genital herpes. So as a general concept, most of sexual transmitted disease in male or female genital tract, they can present it, most likely to be presented with ulceration. Characteristically, those ulceration can be either painful or painless. So we can divide the genital ulcer as painful ulcer or painless ulceration. ومن هذا يعني من هذه الطريقة ممكن نقسمهم in two table with different diseases. نبدو بالpainless genital ulcer conditions. عندنا في الجدول هذا 3 حالات including syphilis, lymphogranuloma venereum, and granuloma inguinale. Those 3 conditions associated with painless ulceration, and how we can differentiate between the 3. So syphilis caused by Treponema pallidum. The ulceration is well circumscribed, also known as chancre. It's associated with painless lymphadenopathy. For lymphogranuloma venereum, is caused by Chlamydia trachomatis, serotype L1 and to L3. The ulcerations are small, shallow, and usually associated with painful lymphadenopathy. So lymphogranuloma venereum, painless ulcer, painful lymphadenopathy. Granuloma inguinale, caused by Klebsiella granulomatis. The ulceration characteristically shows excessive granulation tissue. It's painless ulceration and no lymphadenopathy. In contrast, for painful genital ulcer disease, we have only 2 conditions, chancroid and genital herpes. Chancroid caused by Haemophilus ducreyi. The morphology of chancroid is deep ulcer with grayish base. The ulcer is painful, and the chancroid associated with very painful lymphadenopathy. So from the name ducreyi, so the patient will cry from the painful ulcer and painful lymphadenopathy. Genital herpes is caused by herpes simplex virus, mainly type 2. In some cases, it can be associated with herpes simplex type 1. The morphology of those ulcers are small group of ulcer with shallow red base. The initial manifestation of genital herpes simplex infection, it's small vesicles, then they will rupture and form those painful ulceration. It's painful ulceration with mild lymphadenopathy. An important aspect of genital herpes is a microscopic manifestation under the microscope findings. So the infected keratinocyte with herpes simplex will show multinucleated giant cells, ground glass nucleoli, and cow dry type 1 intranuclear inclusion. Those three features are considered viral cytopathic changes associated or induced by the herpes simplex virus. This is very high yield. And next condition, it's an inflammatory conditions, and we will demonstrate the most important inflammatory conditions in one of the most important inflammatory condition in the penis. It's lichen sclerosis atrophicus, and from the name, يعني من الاسم of this condition we can understand the histologic feature. So lichen refer to lichenoid-like inflammation. Sclerosis, that means it has some sclerotic changes. Atrophicus, it has some atrophic changes. So it's lichenoid inflammatory condition with sclerosis and atrophy. So the definition of lichen sclerosis atrophicus is interface lichenoid dermatitis with band-like hyalinization. So شنو هما clinical feature or the clinical manifestation of lichen sclerosis atrophicus? Usually the patient presented with white atrophic patches with petechiae and affecting the glands and the foreskin. It's atrophicus lesion, but it can show some hypertrophic and hyperplastic foci. Those hyperplastic foci can be associated with intraepithelial neoplasia. يعني لازم نركزوا لما نشوفوا الهايبربلاستيك foci in background of lichen sclerosis atrophicus لأنه can be associated with those precancerous lesion. 9% of patients with lichen sclerosis atrophicus can develop squamous cell carcinoma. So it's important in the clinical practice. يعني it's مهم جدا إن الclinician or dermatopathologist or dermatologist pick up those cases. So we will practice how we can come up with the diagnosis of lichen sclerosis atrophicus. This is an exercise of clinical vignette of a 70 years old male or man who presented with white atrophic patches with petechiae on the glands, and he underwent diagnostic biopsy. The clinical impression was suspicious for lichen sclerosis atrophicus. هذه الصورة, it's an image from the lesion from this man, starting from the surface epithelium. So we can see a thick band of hyperkeratosis, atrophic epithelium, squamous epithelium. We have this wide band of hypocellular sclerotic subepithelial area. Then we have a band of lymphoid infiltrate beneath this sclerotic band. Within the sclerotic band, we can appreciate scattered dilated capillary here and there, and within this sclerotic band we can appreciate the pinkish collagenous deposition in this area. So all those manifestations make up of the histologic feature of lichen sclerosis. Also those histologic manifestation reflecting the clinical presentation. يعني بصورة تانية, white patches because of this hyperkeratosis, atrophicus because we have a thin atrophic squamous epithelium, and it's sclerotic because we have this sclerotic band. So those are the three component makeup, the three histologic feature make up for the clinical diagnosis and the clinical manifestation of this condition. In this slide, it's just like summarizing the clinical the microscopic manifestation of lichen sclerosis. The third part in our lecture is the tumors. So the tumors will be divided in benign genital warts and squamous cell carcinoma. benign tumor or tumor-like condition, in parentheses, the genital wart. Genital wart, also known as condyloma acuminata, defined as benign warty growth of genital skin or anogenital skin. The same condition can be seen in the female genital and anogenital area. Condyloma acuminata, 85% of those conditions or this genital wart are positive for low risk HPV, specifically serotype 6 and 11. Risk factor for genital wart. So بصفة عامة الجينيتال wart are considered as a sexual transmitted disease, and it's transmitted through skin contact with uninfected partners. Patients mostly affected are uncircumcised. It's more common in patients with multiple sexual partners, and can be seen in those patients usually they are smokers with alcohol abuse disorders. So the morphologic feature of condyloma acuminata and in parentheses genital wart, as we see in this picture, we have this like wart exophytic lesion. It's multifocal, so can be single or multiple, sessile or pedunculated. They have this like papillary cauliflower-like lesion or exophytic proliferation. It can range from small tiny millimeter to several millimeter in diameter. And the microscopic picture, we can see the branching papillary structure with prominent keratosis and parakeratosis and prominent lymphovascular fibrovascular component. So we have the papillary structure and we have fibrovascular part. The squamous epithelium, it's proliferating with a lot of keratinization and as hyperkeratosis and parakeratosis. This picture shows a medium power view of a surface of condyloma acuminatum, demonstrating the preserved maturation of squamous epithelium. As we see, the nuclei get smaller when they reach the surface compared to the basal layer. Also, we can appreciate the choliocytic changes in this like picture with perinuclear cytoplasmic vacuolation or clearing. This is known as choliocytosis. The choliocytosis is the cytopathic changes associated with HPV, characteristically including clear cytoplasm, bionucleation, large gray hyperchromatic nucleoli, and wrinkled nuclear membrane. The wrinkled nuclear membrane, like I can draw it like this to demonstrate the name. Also, we call it resinoid nucleoli. Resinoid nuclei, it's like resinoid means beep. يعني النيوكليوس هو اللي شكلها زي الزبيب. And this is an example for resinoid or wrinkled nucleoli. This is a clearing of the cytoplasm or perinuclear clearing. This is bionucleation. We have one nuclei, other nucleoli, and we have a couple of hyperchromatic grayish nuclei as well. So this is very high yield. One additional information, choliocytic changes can be seen in the low risk HPV and high risk HPV. So malignant tumor. So malignant tumor in penis will be squamous cell neoplasm as carcinoma in situ or invasive squamous carcinoma. Squamous carcinoma in situ, also known as penile intraepithelial neoplasia, It's divided in two subtype or two type based on the etiology. The first one, it's non-HPV related, also known as differentiated intraepithelial neoplasia, and HPV related, also known as undifferentiated intraepithelial neoplasia. and يعني وتو نقول علاش واحدة نقولوا لها differentiated intraepithelial neoplasia والتانية نقولوا لها undifferentiated intraepithelial neoplasia based on the histological morphology. Non-HPV or HPV negative intraepithelial neoplasia, they will show a squamous maturation with keratinization, and it's HPV negative and associated with lichen sclerosis atrophicus. In contrast, HPV related or HPV positive intraepithelial neoplasia, the histology will show associated with a frank malignant cells with no maturation or keratinization. HPV related intraepithelial neoplasia, it can be manifested in two diseases as Bowen disease and Bowenioid papillosis. Bowen disease and Bowenioid like شبيه بيه، oid معناها شبيه لكن مش زيها. نقولكم علاش في next slide. So, and usually it's commonly associated with HPV 16, 18. Also other high-risk HPV has been reported to be associated with HPV intraepithelial neoplasia. هذا الجدول summarizing a comparison between HPV intraepithelial neoplasia and non-HPV related intraepithelial neoplasia, including the common location, the gross manifestation or the clinical manifestation, HPV status, precursors, association with lichen sclerosis, and type of squamous cell carcinoma associated with those intraepithelial neoplasia. تو نجو لل histological manifestation of intraepithelial neoplasia. راح نعطيكم مثال واحد على ال HPV related. This is a low power view showing a comparison between non-neoplastic to the neoplastic squamous epithelium. In non-neoplastic squamous epithelium, we can see single basal layer. Here in the neoplastic part, we don't have single cell layer, basal cell layer. In the non-neoplastic epithelium, we can appreciate the maturation. So the cells, the nuclei of the keratinocyte become smaller as they reach the surface. However, in the neoplastic cells, there is loss of maturation, and everything looks the same from the basal layer to the top. So we have larger nuclei on the surface here as well. So this is a medium power view showing like a close-up more features of the neoplastic compared to the non-neoplastic epithelium. This is the non-neoplastic basal layer. We have the basal layer is well polarized, perpendicular to the basement membrane. كمقارنة للneoplastic epithelium, the basal layer is haphazardly organized. يعني جزء من cells are perpendicular, those are laying flat, so they already lost the polarity of to the basement membrane. يعني زي ما نشوفوا هنا cells they get smaller as they get to the surface. However, here in this in the neoplastic epithelium, they look the same. The bottom and the top of the this area looks the same with the same size. there is no increase of a mitosis in the non-neoplastic area. We have frequent mitosis, numerous mitosis here. We have high NC ratio. We don't have high NC ratio in non-neoplastic epithelium. And we have some apoptotic keratinocytes scattered here and there. So, and this is high power view to demonstrate this is mitosis, another mitosis, and this is another mitosis, 3 mitoses in one field. We have a frequent apoptotic keratinocyte with clumped pycnotic nuclei and pinkish cytoplasm. We have hyperchromasia with high NC ratio and pleomorphism. Some nuclei are small, some are big, overlapping and crowding. There is no polarity and there is no maturation. So in this slide, we will summarize the differences between Bowen disease and Bowenioid papillosis. The main important feature or differences between the two diseases or two conditions is the Bowen disease. 10% of patients with Bowen disease will have invasive squamous cell carcinoma. On other hand, Bowen papillosis never develop invasive squamous cell carcinoma. يعني ببساطة Bowen disease it's a precursor for invasive squamous cell carcinoma, and Bowenioid papillosis will never progress for invasive squamous cell carcinoma. Both conditions are associated with HPV infection, high risk HPV infection, but we should like the main difference is one will progress for invasive carcinoma and the second one, Bowenioid papillosis, will never progress to squamous carcinoma. Actually, interestingly, it can regress spontaneously. Next topic will be invasive squamous cell carcinoma of penis. يعني زي ما قلنا intraepithelial neoplasia or carcinoma in situ, it's a neoplastic process. It's limited to the basement membrane. There is no invasion beyond the basement membrane. In contrast, invasive squamous cell carcinoma, it's malignant squamous neoplasm that invade through the basement membrane to the submucosal tissue and adjacent tissue as well. This gross picture demonstrates tumor of the glands that invade the foreskin. So this is the foreskin, and we have carcinoma invading into the foreskin, also carcinoma invading into the urethra. Invasive squamous cell carcinoma epidemiology. The squamous cell carcinoma, it's accounting about 10 to 20% of male malignancies, affecting middle-aged and older patients between age of 40 to 70. United States has low incidence of squamous cell carcinoma, high incidence in Asia, Africa, and South America. The circumcision is a protection from the squamous cell carcinoma, as it's extremely rare among Jews and Muslims male. So this is a list of risk factors of invasive squamous cell carcinoma, including phimosis, lack of circumcision, HPV infection, high risk HPV genotype, history of genital wart. Genital wart itself is not a high risk, it's not a precursor for invasive squamous cell carcinoma, but genital wart is associated with high risk behavior that may associated with infection with high risk HPV. multiple sexual partner, poor hygiene, smoking, immune suppression, and chronic inflammatory condition including lichen sclerosis atrophicus. So as we زي ما قلنا إن ال HPV high risk is considered as an oncogenic virus, can lead to squamous cell carcinoma in situ, also associated with invasive squamous cell carcinoma. So the pathogenesis of HPV infection. So high risk HPV will integrated in some cases HPV will integrated in the genome and or DNA of the keratinocyte and will overexpress E6 and E7. E6 and E7 have different will play a different roles in cell proliferation and neoplastic process. E6 will inhibit P53, E7 will inhibit retinoblastoma gene. Those two genes will promote cell proliferation and suppress the apoptotic or like programmed cell death. Increased cell proliferation and immortalization of the infected cells will lead to tumor development as either as like in situ carcinoma or intraepithelial lesion or frank invasive carcinoma. So the morphology of invasive cell carcinoma in the penis can be exophytic, papillomatous growth, or flat indurated lesion, ulcerated and endophytic. So those illustration shows a different growth pattern. This one shows like exophytic component with minimal invasion, like limited to the superficial part of the lamina propria. This demonstration is a flat growth of the lesion with minimal invasion to the submucosal tissue, and this example demonstrating surface ulceration with endophytic growth deep to that tissue. Microscopically, squamous cell carcinoma has two main morphology. The most common morphology will be the squamous cell carcinoma usual type or conventional type with squamous differentiation. When we say the squamous differentiation, that mean like يعني لما احنا نقول usual type or conventional type squamous cell carcinoma, we try to emphasize keratin formation, like keratin production. As we see here, it's keratin pearl. Those like keratin pearl. Those are malignant cells nest of keratinocyte. It's well differentiated squamous cell carcinoma with prominent keratin production. So squamous cell carcinoma usual type composed almost half of all cases of penile cancer. Squamous differentiation, this is the most common manifestation, and usually it's HPV negative carcinoma. In contrast, basaloid carcinoma, it's HPV related. Usually those basaloid carcinoma عندها blue cells different from pink cells. There is no keratin production, and they look as poorly differentiated or higher grade component. Those tumor basaloid carcinoma, it's already grade 3. A usual type can be graded as grade 1, grade 2, and grade 3, well differentiated, moderately differentiated, or poorly differentiated. In contrast, basaloid carcinoma, it's already high grade, and that will be classified as grade 3. There is no or minimal keratin differentiation, and those tumors usually have a destructive pattern of invasion with aggressive clinical course. شنو هما البروجنوستيك factor of penile carcinoma? The first one, it's the histologic subtype. Well-differentiated carcinoma, conventional type, verrucous type, grade 1 tumor usually have better prognosis compared to poorly differentiated carcinoma, including sarcomatoid and basaloid carcinoma. Those are grade 3 and they will have a worse clinical behavior. Vascular invasion and perineal invasion also associated with aggressive clinical course. Tumor extension, limited tumor compared to advanced tumor extension will be associated with aggressive clinical behavior, and lymph node metastasis also will associated with worse prognosis. and هذه آخر سلايد في المحاضرة. في هذه السلايد I'm trying to emphasize the most two important point out from this lecture: squamous cell carcinoma of penis and condyloma acuminatum, genital wart, those both conditions associated with HPV infection. Squamous cell carcinoma of the penis can be HPV positive and HPV negative. HPV positive will be associated with high risk HPV serotype 16 and 18. Condyloma acuminatum is benign condition associated with low risk HPV serotype 6 and 11. The choleucitic changes is very important to memorize and make sure that you're familiar with. It's vacuolated keratinocyte, showed the cytopathic changes characteristic for HPV infection with perinuclear clearing, vacuolation, hyperchromatic nucleoli with wrinkled nuclear membrane. And this is the last slide of our lecture, including the references. And if you have any question, please contact me in this Facebook group. Thank you.